Okay. So, all right, so let's talk about quadriceps weakness. When are the quadriceps muscles most important?
Foot flat.
Foot flat, yes. Moving into foot flat, moving into mid stance. Absolutely. That's when it's most important. So really, foot flat. So when I'm going into foot flat, remember on initial contact, my knee is in 0 degrees, so it's in neutral, it's in full extension, 0 degrees. So that's to allow me to reach out to put my foot on the ground. Going into foot flat, my knee has to move into 20 degrees of flexion. How does it get there? Concentrically or eccentric?
Eccentric quad.
Eccentric quad. So the quads are lowering me down for shock absorption. Remember, it's when you jump and your knees don't bend, shock absorption. So I needed to lower me in 20 degrees in foot flat for shock absorption. Then I need quads to concentrically contract to help pull me back into full extension so that when I go into mid stance, screw home mechanism can operate. And now it locks my knee instead of my quads contracting. So foot flat going into mid stance is when the quads are the most active. Okay, so if I'm going into foot flat and my quad, it does not want to function. So let's say it will get me, I'm going to force it to be in foot flat, but I really need it to push me back into extension for mid stance. I really needed to do that for mid stance, but it doesn't want to do that. Then I'm going to have to manually control my knee to do that. So I'm going to push my knee into extension from that 20 degrees of flexion so that I can go into mid stance. That's called quadriceps gait, where I'm having to force my knee back into extension so that I can go into mid stance to swing my opposite leg. So that's quadriceps gait. Okay. So, trying to prevent. So it's controlling the flexion and pushing it into extension. It's trying to do what the quadriceps does not want to do independently. Okay? If I have hamstring deficits, I'm going to see that in a couple of different places. One is in mid stance, because in mid stance the hamstrings contract to prevent what from happening? Genial recurvatum, hyperextension of the knee. So if I don't have adequate control of my hamstrings, I'm going to walk with genial recurvatum, popping back onto my knee. You'll see this a lot with hemiplegic gait. They'll walk and hyperextend their knee to try to control their gait pattern. It's very painful looking.
Don't they also walk toe first instead of heel first?
They have plantar flexion spasticity. So they will walk and they'll have a lot of recurvatum. That plantar flexion forces them into recurvatum. So it's a lot of pain. Okay? And then the other place I'm going to see weak hamstrings is in terminal swing with gait. Remember, terminal swing, I'm trying to slow the leg down because I'm getting ready to put it on the ground with initial contact or heel strike. So if I can't slow it down, then when I'm going into terminal swing, I get an excessive knee extension. It's like a knee hyperextension, click. You'll see it when they kick, it look like that. So they'll have poor control over knee extension. And it'll almost kick out until they finally can get control. So those are the two areas where I will see hamstring deficits. During mid stance, trying to control recurvatum. During terminal swing, controlling the actual terminal part of swing of the knee, slowing it down. Okay, so the ankle has a couple of different things that can go wrong with it. Okay, so let's talk about, we can either talk about it from a stance phase or a swing phase or a fixed deformity. So the ankle can have problems. Let me erase all of that. So the ankle can have problems in stance phase. So we can have a stance phase problem. We can have swing phase. Or we can have where we almost have a contracture or deficit of movement. Okay, so let's talk about the easiest one to talk about. I have a contracture or significant movement loss. So let's say with my foot, I have a plantar flexion contracture, meaning my foot stays in plantar flexion all of the time. It's in constant plantar flexion. I had something to happen, either a fracture or something happened, and now my foot, or neurological condition, usually you'll see these a lot with neurological condition, and my foot is in constant plantar flexion. I have a contraction of plantar flexion. Then I'm going to walk with what we call equinus gait. So it's always going to be in plantar flexion. No matter what I do, I can't dorsiflex it to stop. I don't have the control. It's in constant plantar flexion. That's called equinus gait. Always constantly in plantar flexion. Plantar flexion contracture. Usually seen more with neurological conditions than anything else. Okay. Let's say I don't have a contracture, but I do have weak or neurologically inhibited dorsiflexors. Let's say my dorsiflexors don't want to work for a prolonged period of time, or they are dysfunctional from working. So I don't have something neurologically forcing my foot into plantar flexion. So that's a neurological condition that's forcing my foot into plantar flexion. This is a condition where I have either weak or absent dorsiflexors. So I have weak or absent dorsiflexors. I'm not plantar flexed. I'm not forced into forced plantar flexion. I just have weak or absent dorsiflexors. So if I have weak or absent dorsiflexors, when do I need dorsiflexion the most? Okay, so in stance, I need it in initial contact. I agree. Stance, I need initial contact and going into,
Toe.
so initial contact leading me into
Foot flat.
foot flat, yes. Because how do I get my foot flat from initial contact?
Eccentric. Tier.
Jibba lubba go jubba, papa goppa loba.
Eccentric tier.
Yeah, she did till something, muscle, something work. Yeah, I agree. Tib anterior, yes. What about? Keep going. Develop the whole thought.
Eccentrically lowers.
There we go. Great job. There we go. Tib anterior long toe extensors eccentrically lower my foot to the ground from initial contact to foot flat, or from initial contact to loading response, I guess so, or heel strike to foot flat. So I need tib anterior to maintain me in neutral position on initial contact, and I needed to then eccentrically lower my foot to the ground on foot flat. If I have absent tib anterior or very weak tib anterior, when I try to load my weight on initial contact, it's not going to be able to do it. So instead of hitting the ground with my rear foot, I'm going to hit the ground with my midfoot. My foot is going to hit the ground flat. And when it hits the ground flat, because it doesn't have dorsiflexion control, it's going to slap. And that noise is what the stance phase dysfunction is named after. Foot slap.
The same thing as foot drop.
Well, foot drop is the problem that is caused by it, but foot slap is the name of the dysfunction. So the actual drop foot is the problem. The gait deviation is going to be called foot slap. So, so when I'm walking and I don't have adequate amounts of tib anterior, when I go to initially contact the ground, then I am going to slap the ground. So, and sometimes they'll work hard to control the sound, but you will see it. Like you'll see people land mid-foot when they're walking. I see people doing it all the time. It's always interesting because I just sit and stare and I'm like, oh wow, that's foot drop. I want to record it, but that's really illegal. But it's amazing. But that's the concept. They may control the sound, but you'll see the dysfunction. May not be as loud, but you'll hear eventually the foot slapping the ground because they don't have dorsiflexion control, concentrically or eccentrically, going from initial contact to loading response or heel strike foot flat, depending on the terms you use. So that's the dysfunction in stance phase. Okay? In swing phase, when do I need tib anterior dorsiflexors the most?
Get off the ground once you see.
Not pre-swing is kind of important, but there's one that's vital. Mid-swing. Because remember, pre-swing or acceleration pulls me from about 15 degrees plantar flexion to about 10. Mid-swing pulls me from 10 to neutral. That's where I get foot clearance for that 1 centimeter that I need for my swing phase. So mid-swing is the most vital component of tib anterior and long toe extensor dorsiflexion in swing phase. That's when I need it the most. Okay, so let's say I don't have it. The muscles are weak or they're absent. Then when I go to mid-swing, instead of my foot coming up to neutral dorsiflexion, my foot is going to stay in plantar flexion consistently. So it looks like my foot is dropped. So that's where we get the name foot drop. So when I'm actually unweighted, trying to move my foot through swing phase, my foot will be in a plantar flex angle and not in neutral in mid swing, so it looks like my foot is dropped. So I have drop foot. So that's the condition. So that's what we have. That's the dysfunction name, but it's not the gait deviation. So that is the dysfunction name, foot drop or drop foot, depending on who you're talking to. People will name it either way. The gait deviation that I will see because I have drop foot or foot drop is I am now going to have to create the 1 centimeter space needed that my dorsiflexors don't create. So since my foot can't pull itself up, I'm going to have to create that distance needed so that my foot will clear by that 1 centimeter. So the way I'll create that is by excessively flexing my hip. And when I do that, it looks like I'm doing this. And it combines with the putting of my foot down. So I have in mid stance, I have what's called steppage gait. Excessive flexion of my hip to clear my foot the 1 centimeter. So if I can't do it at my ankle and my hamstrings aren't contracting to control my knee, then I'm going to have to contract something that's actively doing it, my hip. So I have steppage gait from my hip, excessive hip flexion, and then foot slap when I get ready to make initial contact. So you'll see them using steppage gait, excessive hip flexion. There we go. These shoes are a weird noise, but steppage gait.
Can that happen in swing and stance or just stance?
So that's what I mean. The difference is in which phase. So in stance phase, what I'm going to have, what my deficit will be, is going to be foot slap. Because I don't have concentric and eccentric control, so it's going to slap the ground. In swing phase, my deficit is going to be steppage gait. So it depends on which phase, you're going to get two different problems. So if I'm in stance phase, I'm going to have foot slap. But if I'm in swing phase, then I'm going to have steppage gait. So you'll want to know the difference, because they'll ask you a board question about one of the other phases, and they'll say, you know, what gait deviation do you expect? You know, Mrs. Johnson is a 48-year-old lady, post ACL repair from a motor vehicle accident. She had some compartment syndrome problems over her lateral aspect of her knee and proximal thigh. And now she has dysfunction with her deep perineal nerve. What gait deviation do you expect her to demonstrate in stance phase? See how that works? So that's a type of question you would see on the board. This patient has this injury, this problem has now caused this, what's the gait deviation? So the compartment syndrome, remember compartment syndrome, post-surgical, it's the swelling, it affects the fascia. You can have compartment syndrome right over the lateral aspect of the leg where common perineal nerve is splitting to become superficial and deep perineal nerve. And it can affect deep perineal nerve, you lose dorsiflexion. It happens. So post knee surgery, one of the first things I like to go in and check, does my patient have dorsiflexion, plantar flexion? Dorsiflexion primarily, inversion, eversion as well. Because the dorsiflexors of the ankle are innervated by which nerve? Deep perineal. Everters?
Also,
It's not deep, just perineal.
Superficial perineal. There we go. So when I go in to check my patient after they've had knee surgery or anything done on the lateral aspect of their leg, I check to see if they can dorsiflex and evert. So what am I checking? To make sure that there is no compartment syndrome over common perineal nerve. Quick way to check it. Told you this stuff is fun. When you put it all together in your head, you go, man, stuff makes sense. I can see it, I can feel it, I can touch it. All right, so here we go. Any other questions about the difference between equinus gait? Now this is somebody who has plantar flexion contracture. The foot is stuck in plantar flexion. They're going to have a contracture of plantar flexion. They won't be able to dorsiflex. It's going to be locked into plantar flexion. Versus somebody who has weak or absent dorsiflexors. So even if I have absent deep perineal dorsiflexion, my foot is not stuck in plantar flexion. Does that make sense? So that's that. Those are the differences there. Alrighty. Any other questions about any of those? Okay. Now, let's talk triceps surrogate next. So, when do I need gastrocsoleus the most?
Not terminal.
Say it a little bit louder.
push
Push off. When do I use push off?
Oh, where's terminal?
Mid stand or in the terminal.
Mm.
Hill.
There we go. So, you said terminal stance?
I was thinking terminal to hill off, but, I mean, yeah.
Heel off, yeah. Heel off is the one. Is where I'm going to need it the most. Heel off, but yeah. So, or terminal stance. Yeah.
Yeah.
Yeah. That's. I was like, terminal stance sounds right too. Yeah. So heel off, terminal stance, both are right. Absolutely. So when I'm in heel off, so remember, so what is gastrocsoleus' job? We talked about it. It switches during this phase. Like in the early part, it's doing one thing. In the late part, it does something totally different.
It controls.
It's
Eccentric plantar flexion.
early.
So it's eccentric early, slowing down the motion because the motion is occurring because of momentum. Very good. So early phase, momentum is controlling everything. So it's slowing it down, pulling the reins. Don't go too fast. Whoa, whoa, whoa. By the time my heel actually comes off the ground, now it's going to switch and become concentric so that it can perform push off, which gives me step length. The push off gives me step length. So on here, I push off and that gives me step length. If I don't have that, then I don't create a step length. So if I have a weak gastrocsoleus, or if I have a torn gastrocsoleus, that's the way I'm going to walk. I won't be able to push off. So my step is going to be, my step length is going to be shortened because I can't push off. I need gastrocsoleus to create that motion. Push off. Give me the distance. Yes. If I don't have it, shorten step length. Because I have no push off. Make sense? So terminal stance, heel off. Very good. Woo! Alrighty. Now let's see which other ones we have. Okay. Let's take a break. Let's see if we can find some of these so that you can see them. Alrighty.